Hi there, I'm Dr. Martin Benfield. I'm a GP trainer, and this video is about talking your thinking out loud, in particular reference to the differential diagnosis list. So the idea with talking your thinking out loud is the patient leaves the consultation understanding why you made the decisions that you did, and obviously for differential diagnosis, and then for the treatment, why you gave the advice that you did. It also enables the patient to identify any misunderstandings that you have, so that you come to the best decision and hopefully shorten the consultations, because you won't be going around in circles where the patient doesn't agree and you're not sure why. The more transparent your questions were during the data gathering, the easier this process is. So if the patient understands why you're asking the questions, then they'll be understanding as the consultation goes on where the consultation is going. The last video actually was a talking out loud example, and in that situation it was helping the patient understand the decisions or the issues that were going to be discussed during the management section. It probably sounds obvious saying it here, but the first step is to tell the patient that you are about to start talking about the diagnosis. And this is a signposting that lets the patient know the stage of the consultation you're at. Remember, you know what's going on in your head, but the patient doesn't. So try something simple like, okay, let's look first at what has been causing your symptoms. There's always more than one possible cause for symptoms, so you would usually describe more than one cause, or at least talk through how you made your decisions. And it does take some practice to do this well, so please keep practicing this. Have a think about how it went and how you could do it better each time. The balance with this kind of discussion is to maintain the confidence of the patient. They need to trust your decision. A good habit to be in is an opening phrase, something like, there are a few things that could cause the symptoms you describe, or there are a couple of things that could cause these symptoms that you describe. I once read a quote from someone, not sure who, and it said, patients don't want your tests, they want your confidence. If a patient isn't confident that you know what you're talking about, then no amount of tests are going to help, because they're going to assume you didn't order the correct tests. It's also worth knowing a study a few years ago into antibiotic prescribing for children found that the majority of parents didn't actually want antibiotics prescribed. They wanted the reassurance that they weren't needed. So there are a few factors to think about when deciding the order of your differential diagnosis discussion, what to say first, what to say second. Factor one would be what does the patient think is most likely? What's their ideas and concerns? Number two would be what do you think is the most likely cause? And then number three would be, is there anything you're really confident about? So regarding the patient's ideas and concerns, they may not be interested in anything you have to say until you've ruled in or out a strongly held idea or concern. So worth making a mental note during the data gathering. Has an idea or concern the patient said, is it a really strongly held belief that needs to be discussed early, or is it just something that crossed their mind that you just need to cover at some point? When covering patients' health beliefs, I try to be positive about their thoughts. It was a sensible thought. They were right to think it. So I can see why you thought about bowel cancer as a cause for your symptoms. Overall, I think there are several other causes that are much more likely, but we can discuss in a minute some tests that we might consider just to be maybe closer to 100%. So here I've been positive about the thought, I've reassured it's unlikely, and I've signposted it. I'm not dismissing it completely, and we will be talking about that a bit later. And then the next stage would be to go on to discuss what I think is most likely, which obviously hopefully will further reassure. The next option was to explain what you think is most likely early. So people remember best what they're told first. So try not to leave this too late in the discussion. And also people might get a bit frustrated if you keep explaining what you don't think is going on and you don't get to the point. Therefore, this would usually come first or second on the list. With the bowel symptoms example, we might follow on with most likely cause for blood on your stool and an ache in your bottom is a hemorrhoid. Another common cause is a fissure, which is a cut, but that tends to cause a much sharper, harsher pain than you were describing. And then you can go into a bit more details explaining the hemorrhoid with sort of relevant reference to the history the patient's given you. Then the third category was start with anything you are very confident about. Now this is really important if there's a lot of uncertainty. Before you start describing what you don't know, get out there what you do know. Get some confidence in the consultation. Now this could be a serious condition that you feel you've ruled out confidently, and obviously if you feel you've done that and the patient has that as a concern, then you start with that on most occasions. Another example is where you could be sure about the pathology process going on, but you can't pin down exactly the diagnosis. So an example could be if a person had a tingling hand, but you didn't feel it was clear enough to say this is carpal tunnel syndrome. So you might say something like, symptoms in your hand are due to a nerve being trapped. What I'm not so sure on is exactly where that nerve is being trapped. A really common place is in the wrist, something called carpal tunnel syndrome, but it's possible to get it from the elbow, shoulder, or even the neck as well. So this kind of approach is very common with phone consultations. You haven't examined the patient yet, so you give a slightly more vague analysis of what you think is going on, so that the patient understands that you give them the confidence you've got an idea what's going on, and then that justifies why they then need to come in to be examined. And you would probably go on to say, what we'd like to do next is to get you down to the surgery, if that's okay, so I can examine you and can try and work out what's causing these symptoms, where that nerve's being trapped. Sometimes it is appropriate to have a guess at the sort of things a patient might be worried about, even if they didn't say they were worried about anything. So for example, for headaches, you can start with, the good news is from the history examination, I can find no evidence of anything nasty, nothing like strokes, brain tumours, that kind of thing. Then you can go on to describe what you think it is and why. So an alternative to this differential diagnosis is talking the patient through the thinking of the timeline. And this is really useful if you want the patient to listen and understand the explanation before you come to your decision. And this is a common scenario in things like minor illness. So let's say we have a child with a runny nose that started 3 weeks ago and a cough, but 3 days ago a new temperature developed and some change of symptoms. Mum's wondering about it being a chest infection, and antibiotics might now be needed because it's been going on for 3 weeks. We're certain there's an infection, and we're fairly certain that it started 3 weeks ago, unrelated to the original cold. The use of antibiotics depends on the current symptoms, background risk factors, and to some extent the parent anxiety as well. So what I'm going to do, I'm going to start with categorising the issues to discuss, including a signpost that we will talk about antibiotics. I'm then going to talk through the timeline of the symptoms, then discussing antibiotics at the end of that with an explanation, and give the parent information about when to reassess if needed, to give them the reassurance I'm not dismissing this antibiotics completely, and then finish with checking, is that okay? Okay, so let's have a look at what's been causing these symptoms over the last 3 weeks and whether or not antibiotics might help. So her symptoms started about 3 weeks ago with what sounds like a normal cold. Her body probably got rid of the infection, the viral infection, within a week, but the immune system, one of the things it does is it keeps producing mucus, and that's why you have a cough for a couple of weeks after. Now things changed 3 days ago when she had the new temperatures and the change of the cough. So the fact that happened suggests that actually a new infection started 3 days ago, completely unrelated to the original cold. Now I'm glad to say when I listened to her lungs, there was absolutely no sign of any pneumonia chest infection. Her pulse was good, she doesn't have a temperature right now, heart sounds were normal, there was no sign of really nasty throat infection or ear infection. So her symptoms are most likely to be due to another viral infection, this time affecting the upper airways, a bronchitis type infection that tends to cause a chesty sounding cough but isn't in the lungs themselves. And the really reassuring thing from the symptoms is that she's had no temperature for the last 24 hours, which suggests that her own immune system has got the infection under control all by itself. And the evidence is, in this kind of infection, antibiotics don't get the symptoms better any quicker, and they certainly don't stop the next infection coming along. So if she was exposed to another viral cold infection in 2 or 3 weeks' time, having antibiotics now won't protect that in any way. Having said that, if she were to worsen with her symptoms, so a temperature came back, or she had any other worrying symptoms like it seemed to be affecting her breathing, then I would want to see her straight away or as soon as possible. Does that all make sense? So in that scenario, antibiotics or not were the main decision to be made for the parent and for us. However, I need to explain my thinking to get to that point rather than explain it from the start and giving that decision at the start and then having a parent who wasn't happy and not really ready to listen because we weren't giving them what they thought initially they needed to have. I'm obviously going to look out for any verbal clues, body language that the parent's not happy. You might need to go into some negotiation, and I'm certainly going to be looking at more detailed safety net after I've checked everything's okay. That example was quite a long monologue actually, so what we'd normally do is be looking for checkpoints where there may be some confusion or you can add in a question and to break it up again, and we will look at that in a future video. So when you're doing your consultations and you're re-watching the videos, when you approach the end of the data gathering, when you're in consultation, start thinking, how am I going to discuss this diagnosis, differential diagnosis, or explain it? And then when you're watching the videos, be thinking that, stop the video at the point where we're about to start discussing diagnosis and have a think, how am I going to do this? And then you can compare what you actually did. Okay, good luck.